joint replacement surgeon, arthroscopy surgeon, trauma surgeon. He does everything, sir.
Everything.
Okay, we are live now. We can go ahead.
Good evening, everyone. I'm Dr. Shailesh Hadgaonkar, and this is the 4th episode of Grand Rounds in Spine Surgery. Today, we have none other than Dr. Arvind Jayswal, the man himself on whom the Delhi Spine Society is standing tall today, and all India. We all know Dr. Jayswal as the ex-head of the department of All India Institute of Medical Sciences, and currently is practicing at Primus Hospital. He is one of the prime member of Indian Spine Society, and one of the real stalwart who is into minimal invasive surgery, who is into deformity surgery, and Dr. Jayswal is significantly associated with Asia Pacific Spine Society, and he is the ex-president of APSS as well. We welcome you on board, Dr. Jayswal, for giving us the time for grand rounds today, and this is a world premiere. We'll be telecasting it all over. Thank you, Dr. Ashok Sham, for giving us this opportunity for the grand rounds. This grand round is supported and affiliated from Maharashtra Orthopaedic Association, Dr. Ajit Shinde, who is an orthopedic and spine surgeon, and he is a constant support for these kind of academic activities to us, and we are really thankful, Dr. Shinde, for your support. We also thank Pune Orthopaedic Society and Dr. Narayan Karne for giving us significant support for such kind of academic activities for spine, and we are thankful to Sancheti Hospital for giving us the platform for this world premiere today. Me, myself, and Dr. Abhay Nene, who is from Mumbai. We all know Dr. Nene, who is a true academician, will be conducting this webinar with Dr. Jayswal, and Dr. Abhishek Srivastav also will be joining us in some time, as Dr. Anant Tambe, who was supposed to be there, and he's got some emergency, therefore he's not yet joined us. And we see how it goes today when Dr. Tambe joins us. But in the meantime, we proceed with our grand round on time. Over to you, Dr. Shinde, sir.
Good evening, dear colleagues. I am Dr. Ajit Shinde, President of Maharashtra Orthopaedic Association and Chairman of IOCON 2020 Organizing Committee, Mumbai. Welcome you all for today's webinar on live grand rounds with Masters of Spine Surgery world premiere. With the advent of modern technology, I fear that the newer generation surgeons may lose their clinical touch with the patient, which can impact very negatively on their clinical ability for diagnosing a particular issue. In our times, we routinely used to see patients and assess them on our clinical ward rounds, which are further furnished by grand rounds by respected senior and faculties. But this very art is now on verge of becoming absolute day by day due to advancement in electronic telecommunication as well as radiological fields. So I really appreciate our team to consider this topic for webinars, and today is the 4th episode of series on grand round in spine. We should not forget that our clinical touch and physical contact with patient is of utmost importance, not only to establish proper diagnosis by thorough clinical examination, but also to form a strong emotional bond of trust and compassion with the patients, which will surely help you a lot throughout the further management of them. Thus, recognizing the very importance of grand rounds, we have with us today's renowned Dr. Arvind Jayswal, spine surgery stalwart from Delhi, ex-professor HOD of AIMS, and Dr. Anant Tambe, an international spine master from Manchester, UK, to guide us all regarding the grand rounds in field of spine surgery. I am very much sure our experienced duo of spine surgeons, Dr. Shailesh Hadgaonkar from Pune and Dr. Abhay Nene from Mumbai, will convey this webinar very smoothly yet efficiently. I also appreciate effort of Dr. Ashok Shah and Neeraj, who are coordinator for today's session. My best message for today's webinar: Thank you very much. Now I hand over to Dr. Shailesh Hadgaonkar and Dr. Neme. Thank you.
Thank you, sir. Thank you for the kind wishes and your support. I welcome Dr. Abhishek Srivastav. Dr. Abhishek is practicing at Primus Super Specialty Hospital in Delhi, and he is one of the very known figures in spine circles in the country. Dr. Abhishek is trained extensively in Delhi and in England, and he got his training in Nottingham. And but currently, he and Dr. Jayswal are heading the department in Primus Super Specialty Hospital in spine surgery. I welcome you, Dr. Abhishek, for giving us time today for this world premiere and grand rounds in spine surgery. Looking forward for your constant support, and over to you, Abhay.
Thank you so much. And I'd like to share the screen, Shailesh, if you can discontinue sharing.
It is.
So we are actually, this is a very special occasion because this is a grand round with the masters. We've got some fantastic masters who are, who are with us on the round. The concept of this evening is that we take everyone through a series of cases that have been admitted in the wards. And we don't know what to do with them. And we'd like the opinion of the masters. Here we have Dr. Jayswal himself, who's been my guru, who's the guru of spine surgery in general. We have Abhishek Srivastav, who, like me, has learned a lot from Dr. Srivastav, and now he himself is a very, very well-known surgeon in the country. Anant Tambe, my cousin and a spine surgeon from UK, will join us. He's operating a orthopedic surgeon's mother in Manchester, so he's been nailed right now. And of course, Dr. Hadgaonkar, my colleague and from whom I keep learning a lot. So we have a lot of masters here, and forgive the residents for the COVID outfits because they need to be in all the wards, but we are fine. So we'd like you to attend to this first gentleman who's a bit of a VIP. He's a orthopedic surgeon's father. Yes, Dr. Hadgaonkar.
Dr. Himanshu Kulkarni, who is practicing as a spine surgeon in Sangli, is constantly there. And on all the brochures, his number is there. In case of any query, you can please SMS or WhatsApp to him, and we will try to see how we can get answer from Dr. Jayswal and Dr. Srivastav. Sorry to interrupt, Abhay. Please.
Sure. So if there are any questions on what we are discussing, please message to Dr. Himanshu Kulkarni, who's a very enthusiastic orthopedic surgeon from Sangli, and his number is out there on your brochures. So this first guy is an orthopedic surgeon's father, and we were all set to treat him, and then he realized that Dr. Jayswal is coming from Delhi. So he said, no, don't touch me until I have an opinion from Dr. Jayswal. He's an elderly guy who's basically has had a central cord syndrome. He tripped and fell in the house. He was a compensated stenotic, you may say. He's really had no symptoms other than neck pain occasionally. But he really went down after the fall, and he was treated locally with steroids and rest and stuff. And now subjectively, he's significantly better. He's walking like a spastic independently. But he continues to improve individually. All muscles are fine. There's some, vague loss of grip. And this is, we of course got his MRI done because nothing had been done. And this is what his MRI looks like. You saw his x-rays. He's a very active 73, but he's that way not doing any professional job. So Dr. Jayswal, can we get you right into this one? Because this is the controversy that's, plagued us for, many, many decades. Central cord syndrome, recovering under observation. Should we go in? Very stenotic spine. What's your opinion, sir?
Yeah, this is a genuine problem, and there's a lot of controversy on this. And so the etiology looks as if there was a stenotic cervical spine extensive, and probably he had a extension of the neck, which caused pinching of the cord, which was already narrowed down and pinched from both probably front and back. The question here is to also look and rule out if there's any acute, fracture which will look like, or if there is a, instability there, which is translated into an acute, which had translated as an acute injury, and then manifested an already stenotic canal into being throttled totally. So that's here with the images that you have, it does not seem as if there's a acute fracture or a dislocation or even, a subluxation as such. So this is a classical acute traumatic cervical central cord syndrome. And the good thing is that he started recovering, which is most of the patients do recover. And, conservative management is initially the way to go about this. And majority of the people sort of conserve this and take them along, keep them under observation, and if possible, preferably keep them under admission. See, and steroid, as you rightly said, give them a collar. I would prefer to have a slightly stiffer collar than what he's having, soft collar, and continue.
But
Also,
basically, you're not interested in going in at this point.
not at right away because he's improving. So you see where the neurology is going, if it plateaus off or deteriorating then. But at the moment, I would conserve. Yeah.
Right. Dr. Srivastav, this patient is very well read, and he pointedly asks us that do you think there's any benefit of doing surgery at this point? What are the chances of recovery you're giving me without surgery vis-a-vis with surgery? Because if there's any benefit, I'd like you to go in. How do I counsel him now?
So basically, I would look at it as, a timing issue. Since this presented, it's now been 10 days, and there are the other thing is that he's improving now. So these two things will prevent me from jumping into a surgical solution. If it was, within 24, 48 hours, then, there was a mandate that, we can, go and give an option of decompressing. But given his age and injury which was because of the trivial fall, it is very likely that he will recover over a period of time. So at 10 days, if the patient comes to me and then and is improving also, then I would also sit on it and see how the recovery goes.
But to specifically take his question, I would answer on your behalf that there is no benefit of surgery additionally at this point. Is that what you're trying to tell us?
That's what I want to tell.
Also, I want to
Also,
ask
I would
you on
like
the
to
point that you made about surgery at 48 hours. So you're saying that if you had seen him inside the first 2 days in the same scenario, you would have offered him surgery?
No, I would have discussed the option with him, but still I would have, tried to be conservative. If there was chances of, because within 48 hours, the chances of recovery, you are not able to gauge that much, how much the recovery has happened. Then there is always a discussion of thing happening, about surgery also.
Dr. Jayswal, are you in agreement with the issue of timing that the same scenario, if seen early, you would offer surgery, but if seen late, you won't offer surgery? Do you
not really. I would conserve him. But at the same time, I would conserve him and see how he's sort of recovering. At the same time, like you rightly said, you got to be very clear with the patient and give him all the options. And we can also tell him that the literature is divided on this. Some people go in early, and even the timing, there's not a lot of controversy, whether it's 24 hours or whether it's 7 days. So it's really not much sort of specific guidelines are there as such. And the other thing is that we have to tell him very clearly that look, at some stage it may just plateau off your recovery, or if there's a deterioration, then you may have need surgery right. But at the moment, if he's recovering, then there's a good chance that he will go right through, and that's what the literature says. There's not too much benefit of going in immediately. You go in immediately within 48 hours or 4 days, whatever the timing thing is, if there is a evidence radiologically or imaging wise of any instability as such, or if there's a fracture dislocation.
Right. Very good points from the both of you gentlemen. Dr. Hadgaonkar, I'd like you to come in here. The question here is, are we being very defensive? Because in case he plateaus at 70% and after a month and a half, you talk to him about surgery and he says yes. Have you done him a disfavor when you could have operated him earlier? Do you think that? Or do you think it's okay to operate as late as you wish? You're muted, sir. Dr. Hadgaonkar, you're muted.
I think it's the ideology and the institutional practice and your training. If the improvement is there and the patient is improving 70 to 80%, I think probably there is a chance. This is acute and chronic, and it is ongoing for a long time. So maybe giving the best chances, I will probably wait. In this scenario, I will definitely wait because 70 to 80% improvement is a very, very good improvement. That's what I personally.
The question was that if you waited and he plateaued, he stopped recovering after this, and you had to go in late and decompress him, like Dr. Jayswal mentioned, are you, giving him an inferior result compared to what you could have given because he's open to surgery even now. He's delaying it because you've asked him not to do surgery now.
Okay. Yeah. I mean, if this is a situation, then surgery will definitely give a good answer, because it is probably a 2-level decompression. If you do a good decompression, there is a chance that this compression, because of the disc which is and leading for this central cord like a picture, probably it will get a good benefit if you decompress. There is.
Dr. Srivastav, can I bounce this question back to you? That in case you ultimately had to go in and decompress him, would you have felt that, I should have done this earlier compared to doing it 2 months later?
No, I would not have, because I would have talked to the patient that, out of 100 people, 60 to 80% will get better with conservative care. And this is a choice which we have. And surgery also does not conclusively gives there's no conclusive evidence with the surgery that it, hastens the recovery, and it is the sure shot way of, making you better. So this is a balanced choice which we have to take based on discussion and based on, because there is no level 1 evidence on this. So we have to base our decision based on our training, what we have seen in our follow-ups. And I feel personally that, waiting is not bad when there is a sign of recovery.
Dr. Jayswal, just yes.
What would you do?
I normally go in. I'm normally aggressive unless the patient doesn't want to go in. Doesn't want me to go in. So I wanted to ask you that the patient has heard what Dr. Srivastav has said, and he says, you know what, I think I want you to do surgery on me. At that point, would you refuse surgery because you're convinced that he's recovering, and the surgeon in you does not wants to hold horses, Dr. Jayswal?
No, but like I said in the beginning also, I'll put all the cards on the table and let him take the decision, right? And we'll say that, look, some people have really remarked on the fact that if there's an extensive edema, like this guy has, and if you try to go in, you might worsen the edema in the sense ICU, post-operative ICU care gets prolonged, because the edema may go up proximally, and then when if it hits the base of the medulla, then you may have problems.
So you're trying to say that there's actually some advantage in waiting rather than rushing in.
Some people, and that is mentioned, but it goes either way. So you let the patient know about it, and then the other thing is if the also depending on how bad is the stenotic element there, and if you see it's not really except at one level, the other levels you can see the column of CSF. So we'll have to talk all this to him, saying that he may have a chance of recovering without that. But if I would like to put everything back on to him and then decide.
But if he chooses surgery, you're happy to go ahead?
Yeah, then go ahead. 10 days, yes, I would. Yeah.
Abhishek, what surgery? In case we had to go for surgery, what would be your surgery of choice?
I would go here for posterior instrumentation and decompression from C3 to C7 undercutting.
And why instrumentation? Why not just a decompression?
Because I think that there is a dynamic element to that. Because the injury happened because of the dynamicity of the cord, for the spine. So I want to fix that area because it's a myelopathy. So I don't want the cord to get irritated again and again by movement. Right. That is my...
that instability has played a role in the injury.
Yeah.
So you'd like to counter that. Excellent. Yes. Dr. Hadgaonkar, what would be your surgery?
Also, I would like to add...
Yes.
Sorry.
Yes, doctor. Yes, go ahead.
One thing more, there are studies which show that if we delay the surgery in these patients, the morbidity of the procedure goes down over a period of time. So there are actually studies which show that, waiting reduces the morbidity of the procedure also.
Right. So pretty much what Dr. Jayswal said also, isn't it?
Yes.
That there is some advantage in going in late. Right.
Yes.
So that's good information. Dr. Hadgaonkar, your surgery of choice?
Yeah, I probably will consider anterior surgery in this, maybe multi-level decompression, discectomy, and...
How many levels?
I think 2 level. 2 to 3.
2-level corpectomy or 2-level discectomy?
Discectomy should suffice because there is mainly the disc at 5-6 is the main culprit, and 4.
So you will go here
Yeah,
and
correct.
leave the
And there is one
bones
above.
alone, and you will go take the upper one.
Yeah,
This one.
yeah.
But you would not be happy to do a block excision.
Probably it is not required because there is no OPLL or anything. Just discectomy will give the answer.
And any specific reason for anterior versus posterior for you?
No, I think positioning is safer in anterior. You are not creating a lot of pressure while giving a posterior. In this kind of borderline situations, somehow I personally feel that anterior surgery is safer in terms of positioning for this surgery. 1-2 hours of prone positioning somehow is not. I'm not really comfortable in this kind of compressions and neurology.
Any quick retort to that, Dr. Srivastav? The position in posterior surgery in a tight canal?
I would, slightly differ on that. I think that anterior surgery, it is difficult to control the, neck extension, because this is a usually, hyperextension type of injury. And, we tend to hyperextend the neck in order to gain better access in the, in these patients. So then there is a chance that you might actually compress the cord more. So either you do, so in our practice, we do sometimes position the patient even under monitoring. And we have seen that, signals, they tend to change with the way you keep the neck also.
Right.
So I would be slightly, more, and also there is another thing to it, which I always consider when I'm doing decompression in these kind of cases, is how big is the extent of the edema also. Because edema leads to swelling of the cord. As you can see, the size of the cord is more than what you would normally expect. So I would ideally like to give room to the cord as much as possible. So that
weight
way,
posterior is your way. And indirect.
So I would,
yeah.
So I would like to give the whole edematous cord some room so that, it can have space to breathe and, the inflammation goes down, because the pathology started at one place, but now it is not restricted at one place. It is going all over, top and bottom both.
Right. Dr. Jayswal, we have 1-1, so yours is going to be the final verdict before we move to the next case. What surgery for this gentleman?
Posterior, as Abhishek said, posterior, I totally agree with him. 3 to 7, undercutting 7, yeah.
Implants or no implants?
Implant with lateral mass, yeah.
Always?
Yeah, mostly lateral mass, yeah.
Right. All right, lovely. So we'll pass this plan to the patient and tell him this is what was decided by the experts. Dr. Hadgaonkar, can we go to the next case? So a lot of learning in this one. I think most importantly, the learning was that we should not rush into a central cord syndrome. And especially if it's recovering, there is some advantage of waiting, and you got to counsel the patient and take it at case base. And there is a pro and con for a back and front surgery both. We'll move to the next case.
Is this screen is there, Abhay?
Yes, we can see it.
Hi, this is a patient next to the same patient Dr. Nene showed us, and he's transferred from outside. Is 65-year-old man with multi-level fractures and cauda and bladder involvement, inability to stand and walk. In lying down, neurology is almost 5/5. And this is the X-ray, and extensively treated for osteoporosis for nearly 6 to 7 months. And this latest neurology worsening of the bladder is almost 4 to 5 days. And the multiple fractures, inability to sit for 6 to 8 weeks. Bracing, all the possible osteoporotic medications been given. Blood investigations revealed anemia, hypercalcemia, raised alkaline phosphatase. Means he was treated by 5 to 6 doctors and everything was already done. And this is the MRI. Yes, Dr. Jayswal.
Yeah, can you go to the previous slide, please?
Yes.
He was already being treated, but severe osteoporosis, multiple collapses, raised alkaline phosphatase, hypercalcemia, that should have rung a bell also. And, myeloma screening should have been done right there and then, apparently
yes,
that was.
So this was done, and myelomas, the M band came positive.
So that then you wouldn't be just treating for osteoporosis alone, because the patient, then myeloma, then you get on to chemotherapy and other things, and then you support the patient, with an extensive bracing, right? Can you move on to the MRI, please?
And cauda equina now with the large disc at 5/1.
Yeah.
Bladder involved.
Yeah.
And with all this disability, the patient is demanding that Dr. Jo bhi karna hai, do it once and for all now, because they were like really fed up going to different places, getting admitted and not getting the answer.
Yeah. The other thing I would like to point out here in the MRI is that, and if you have your, in the rounds, if you have your colleagues and fellows coming there, and that's what you see and tell them and point it out to you. When you see compression fractures, right, and then you see a posterior bulging of the posterior cortex of the vertebrae, that's when you start suspecting neoplasm, Mets and other thing. Because in osteoporosis, you would not have a posterior bulging. That's what the radiologists say. But that's not a short sign, but you should start suspecting when you get a posterior bulging into the canal. So that's one point I would like to make. And then also, you have to look at the texture of the vertebral body as well. And if you're mottling up the of the vertebral body, is again more pointing towards a neoplasm, a Mets, or a myeloma, or a lymphoma. So you should start, your thinking should be on those lines. Now the question is, what should we do? Like rightly said, the patient has developed a cardiac finite already 4 or 5 days. And, so the thing is here is to straight away go and decompress. Could you have axials here, please? The axial cuts?
Yes, sir.
Yeah. So actually, it's not very, you can't really specifically say which level is causing this, is it the L4 or L3 or L2? And you're almost there at the corners also, there's a posterior bulge there. So axials, we can't be sure which one is there. But having said that, one has to do a decompression, right? So when you do a decompression, I would like to. Yeah.
Dr. Jayswal, you're looking at the lowest disc, or you're looking at the entire 4 levels of compression?
I can't see a big disc there, really.
Can you annotate?
I'm actually looking at.
Sir, this is the one. It is here. The large disc.
That one. Is that it? Are you sure?
Yeah.
I think the axials are missing it, but
yeah.
If we say there's a chorda equina, that's probably the only explanation.
Yeah, but
I'm expand the photo, Shailesh. Can you expand the photo? Zoom in.
And okay, the soft tissue which is next to that. Yeah.
This one, sir.
It looks more like a soft tissue, isn't it? Vascular or some, not vascular, but a granulomatous mass.
Yeah, but then if you just do a disc excision, right? The bones are really soft, and like he said, if the patient's general condition and if the anesthesia clears you, wouldn't really mind doing some stabilization there also, because the bones. My only concern is just doing a decompression that discectomy there, would and is obviously looks like a huge disc. So you'd have to do a part of laminotomy also there. So you're further destabilizing it, and then that might cause a problem there.
So how many levels will you go for, if at all?
Depends on what is the status of the condition of the patient.
Patient is otherwise medically stable.
Okay, then what
the businessman, the family.
What I would do an open excision and fixation at S1, 5, 4, and address the stenosis there. And upper level you do percutaneous screws right up to 11 or 10.
Up to 11.
Yeah.
D11, okay.
Percutaneous, yeah. The lower one, you do a semi-open, you do a laminectomy and do a decompression, fix it L5, L5, S1, L5, 4, and then do it all percutaneous.
Also, because of this myeloma, there was osteoporosis, the 3-4 level fracture, chorda equina, and osteoporosis.
More the reason why you do a fix high.
Longer construct.
Yeah. And then you can do that percutaneous, the upper ones. You know.
Okay. Okay.
So
Will you go for a iliac screw, sir, here? Because we have only one S1. Will you go for S2?
S1 should be okay. S1 and do an interbody fusion L5 S1 should be okay.
Okay. Yes, Abhishek?
I think, yeah, we can do T10 to sacrum and decompress where the problem is. Because I presume the patient has got significant back pain also before the chorda equina.
Yes.
Yes?
Yes, yes.
And the patient can withstand around 6 hours surgery.
Patient is medically stable. Yeah. Medical fitness was given.
Yeah. So then, we can go from T10 to sacrum, S1, basically.
Okay. D10 to S1. Okay. What about you, Abhay?
I just want to be a devil's advocate and say that if I'm convinced that this disc has really caused the chorda equina, I'm thinking if I could get away with a discectomy and multi-level cement plasty and not get into fixation and back him up with photio, a teriparatide, because that has worked wonderfully in my hands, much better than surgery for these guys. Because I fear if I go to sacrum, that's one of the formulas for this proximal junctional failure. Once you go to the sacrum, there's no movement at the bottom and the lever arm is much higher. So I'm worried that I'll create a monster.
Okay.
So
but in this kind of retropulsed vertebral bodies, are you comfortable in doing vertebral plasty in these 2-3 levels?
It's L3, L2 also. It's below the conus level. So it's at the root level. I'm not so shy to do a V plus C, especially if I find my big culprit at the bottom and I can do an interlaminar discectomy.
Mm-hmm. Okay.
I think doing less is more for this guy.
Okay.
Yeah, so that's what I was saying. You stabilize. I would like to stabilize the decompressed area.
You got a significant back pain, like sitting pain, cannot eat also, that type of a back pain.
Yeah, so
that is why
pathogenic back pain, isn't it? You fix the bones and you're fine.
Is it an instability back pain because of multi-level collapse?
Absolutely, but it's an intraosseous instability. So cementing should do the trick. If it was a disc vertebral instability, you definitely need to fix.
But maybe I think maybe in dorsal spine I'm okay, but here in lumbar spine, where all the loading is coming on the lower back, in a collapse multiple levels, probably I'm not too sure.
My implant will be teriparatide, basically.
He was on extensive medications for all the medical management. Six orthopedic surgeons were treating. So all
the more reason says that it's a messed up medical management. When 6 orthopedic surgeons are treating, they're just giving him 6 varieties of calcium.
Already
treated. They are clueless on the treatment of osteoporosis. I can assure you that.
Not only osteoporosis, Abhay, you have to give anti-myeloma, chemotherapy also.
Yeah, he was good, and oncology.
Oh, he was a proven myeloma.
Yeah.
Then it's magic. Chemotherapy is magic for him. We are absolutely not worried. But then you can't give him teriparatide.
Yes, that's what I wanted to say, that you can't give teriparatide in that scenario.
What would you do, Dr. Hadgaonkar? It's
a
controversial
we did what Dr. Jayswal was talking about. We did the multi-level fixation, and we decompressed that there was a large disc which was there at lumbosacral junction, and we did this D10 to S2, and now nearly 3 years follow-up. He went on for a bone marrow transplant. His pain is significantly better. He comes in between for some amount of pain, but he's walking, and so far he's very happy.
Great.
Excellent.
We didn't do the percutaneous screw, sir, but we did all in one go, open surgery. Yeah.
None of you all would back up your surgery with cement? Anyway? None of the 3 of you?
No, I don't. I've given up cementing. Away to a large extent, I've given up cementing.
We have the videos now. He's walking very, very comfortable.
It's really, long-term cementing is not good in the bone. So
Abhishek, do you cement?
Well, when I was training in Nottingham, we used to cement a lot of them. We never used to put screws without cementing in osteoporotic spine. But over the years, I have moved away from that.
Any specific reason?
It's just that when the screw backs out from the cement, then there's nothing left there. You have to go up, and that's it.
Right.
These are the HA coated screws.
I mean,
So far
cementing,
holding
if you
well.
really want to get an anchor, then I think cemented screws are much better than HA coated.
Yeah. Agree. Various ways. Nowadays we have started using dual core, but they all are the gamut of the similar thing.
But if you fix long, and if you fix the screws are longer also, their ways and to tackle their things, then you can get away without cementing the screws. I don't like cementing anymore.
Yeah.
I have a question for Shailesh.
Yeah.
You didn't do a fusion at L5S1?
We didn't do a fusion at L5S1. We did a posterolateral fusion. We put the graft which we got it from that lumbar segment, and we took some spinous processes and we mixed it.
And you found a big disc fragment, is it?
Yeah, large disc. Yeah. He recovered after 3 to 4 months. He recovered from his that acute thing.
Cardiac improved, huh?
Yeah. Bladder improved. Yeah.
Great.
Which is again a surprise to us. Normally we don't get that, but he was really lucky.
Well, how much in a case like this, when you see the disc, the soft tissue, huge soft tissue, and there is myeloma or a lymphoma, there are times when you suspect that there will be there may be some of the neoplastic element there, not only disc. How much relevance will you give it, and how much would in your practice would you do an MRI with contrast? Does that help?
Yeah, means it is definitely very, very important to have a MRI contrast. Yeah, it is useful. And to our surprise, this patient was treated by a hematologist who is a very aggressive and very good hematologist. And he said after 4 days of surgery, he said, I would like to get transferred under my care. And he started the myeloma treatment very aggressively at that time. Normally we wait for 2 weeks till the sutures are healed and all these things. But he said, no, I want to start it at that. I don't know. What is your opinion on this, sir?
No, myeloma treatment has to be started. It's the radiotherapy where you have a bit of an issue, especially radiotherapy starting the radiotherapy, especially if you have a bone graft there, then that becomes a bit of an issue whether to start your radiotherapy in 3 weeks time or 6 weeks time. But chemotherapy and in a myeloma or a lymphoma, chemotherapy you start, Usually you talk to your oncologist, and if they can wait till the suture removal, then you are more comfortable. But if they have to do it, they have to do it. That's it.
Okay, sir. Yeah, over to you, Dr. Nene, for the next two cases.
This is an emergency that landed in the casualty, but we skipped her. We showed you the other gentleman because he was a VIP. So this lady had a fall from height, and it's essentially a tussle between the ortho and our spine team. She's suffered a fracture of the femur, and she seems to have sustained something up here because she has a neurology in the legs which is unstable. Not unstable, but it's partial. It's not necessarily unstable. And she's otherwise completely stable. There's no ABC is fine. And really, this is the CT scan.
Abhay, can you go back? What's the catheter there?
We've kept a catheter there, but she has preservation of the sensation. So we're not totally sure of her bladder control. She came pre-catheterized, and we've not bothered to take it off. We've not done any urodynamic test. She just came in last night.
Okay, right.
And this is the MR scan for whatever it's worth. So this is basically the situation. And the ortho guys are throwing their weight that they say the fracture femur is unstable. If you don't fix it, she'll keep bleeding. We wanted, to use your influence to try and upsurge them and, do our bit first. But I just wanted your take in this scenario, Dr. Jayswal, how to proceed. It's red hot for us, isn't it? Partial neurology and unstable 3-column fracture.
Yeah, but you're looking at a young person coming to the casualty, and they want to put an external fixator, although they want to do the femoral procedure along with it. It's not a bad idea to sort of go in quickly there with them and sort of stabilize them percutaneously, the fracture, right, without decompressing. Just do a Ligamento Taxes and just stabilize it percutaneously, and let the ortho guys take care of the femoral fracture. Let the patient come back to the ward and assess what the neurology is, and a lot of protocols, they say that in such a type of an injury, you just get a CT scan, the usual CT scan for the entire body, and just stabilize the fractures as such. MRI can be even deferred for a later stage when the patient stabilizes. So in this case, anyway, you have a MRI there. So get an MRI, look at the status of decompression post-operatively, how it is by your Ligamento Taxes. And then if you required, if you're not convinced about your indirect decompression, then you go in and do an open decompression and set it up. But at the moment, it wouldn't be a bad idea to just stabilize it two above, two below the fractures percutaneously, and just do a Ligamento Taxes and let the ortho and the trauma team look at his thigh fracture, and then let
But
him.
so we'll tell them that we want to go in first, and then they can go in.
Yeah, that's the usual protocol. Just percutaneous, and then do it. Yeah.
Dr. Srivastav, I want to hold 2 points which Dr. Jayswal said, because if you see on the, one was the issue of percutaneous fixation, like what's the advantage, and especially time from a time perspective, and the other is the fact that this is a 3-column injury, almost a type C. If you see the bottom left image, there's a rotation and a translation. Is it okay to consider something like a Ligamento Taxes here? And in view of present compression, is it okay to, like, what do you lose by decompressing at that time rather than not decompressing? Like, is it a lot of time that you save, or what? Can you try to clarify these 3 points?
Well, there are 2 scenarios which we have to note. One is that if the neurology is deteriorating, so whether is the neurology, there was an injury, patient had a neurology, and the neurology is stable now.
Yeah,
right?
No, it is stable. It's not unstable neurology.
So that means that the initial hit caused the injury. And as you look, there is reasonable space in the canal. It is best to stabilize. So it is basically the instability which will worsen further the situation. However, because it's an incomplete injury, the patient is very likely to recover over a period of time if we just give a stabilized environment to that injury. I would personally go for an open fixation because, it saves some time, some movement. So I'll open one side, I'll put screws and I'll put a rod and then go to the other side and do it. Or in fact, just put the screws, 2 screws, one up, one below, and then fix it with a small rod, then expose the other side and then stabilize it. That way I can minimize the movement at that area and, do a fusion also in that area more confidently, because it's a type C injury, it appears to me. So that would be
argument for open is that you would like to stabilize one, and then so the intraoperative movements are less.
Yes.
Open, and you will get to do a fusion as a one-time procedure.
Yes, and also
what about
because
Ligamento Taxes, would you think?
Yeah, I think in percutaneous sometimes you have to tap also in order to put the Jamshedi down. So that can, give to repeated movements. That's what I feel. There is no evidence to it. Ideally, what the trauma protocols say is that you have to stabilize it percutaneously in most of the cases where you can do.
What about Ligamento Taxes? Do you think it's applicable in this case?
I don't think there is much role of Ligamento Taxes here, because usually that's more for a, burst fracture kind of situation where you can do Ligamento Taxes and, you can regain the height. But here, as you can see, it has gone through the upper end plate and as well as the disc also, and gone through the whole posterior part. So in fact, if you do a Ligamento Taxes,
Abhay, in the sense that you don't have to do a big distraction with Ligamento Taxes in this particular case, because if you stabilize to above, two below percutaneously, and then actually do the mechanically to put the rods in, it will do some little bit of distraction as it is a Ligamento Taxes and stabilize. That's it. You don't have to concentrate on distracting as such.
So more like a reduction.
I know what the concern is. It's a 3-column, then you're causing distraction to you're causing distraction to the cord. You don't really have to do that. Once you put the rod in, automatically some amount of natural Ligamento Taxes will occur, and it will align, especially in a fresh trauma like that. Okay, you'll be able to stabilize it.
So you're essentially saying your rods will reduce the fracture rather than distract, isn't it?
Exactly.
Just one, we want your comments, sir, on percutaneous. Don't you think it'll get too longer and messier, and you won't have a handle on the fracture while you're doing it, and of course you can't fuse? Like
No,
what
okay.
argument?
If you look at the axials, we can see there is the pedicle also is bursted there. So probably what you're asking, okay, that's a very important
Dr.
question.
Jayswal, percutaneous screw versus open.
No, two above, two below, you don't have to go through that. If the pedicle is fractured, the cuts are not good, but if one side, if the left side is fractured, maybe right is intact, you can pass through that or not. But even if you stabilize to above and below, you're okay if you're scared about the pedicle there. And the thing in the polytrauma, patient is a question of time actually there. If so it's you handle other fractures can be stabilized and see post-operatively, get your CT done, get your MRI done, and if required, then you go in and do a definitive thing. Here you can in half an hour you can put above and below the screws percutaneous and lock them in position and hand it over to the trauma team to
But
fix
both of
the
you gentlemen are very clear that decompression has no role in your surgery in this particular scenario.
Not right away. It's not right away. If it doesn't reduce and if it doesn't, if the compression is not adequate, you can always go in. Your implants are already there. Do a local open and open it and decompress the whatever fragments are there, and then you can go ahead and do it. This is a salvage procedure, an emergency casualty room on immediately when the patient comes in.
Yes,
Especially with polytrauma.
Dr. Hadgaonkar, this is a Puneri patient. This patient is extremely well-read and curious, means her relatives. So they are now asking you as the head of the unit in Sancheti that you've taken the expert opinions. But I have been told that to decompress, it will take you another 20 minutes at best. So why are you not offering me decompression and just, go through the whole thing? Why do you want to come back in? So how do you want me to?
Yeah. This can happen because a lot of people have that Google support with them, and they come with the brochure and they show us why not this. Probably the literature and evidence is not in this kind of partial neurologies. If you just distract and there will be an indirect decompression, and probably we can get away. You do open or minimal invasive. Open probably because of the pedicle fractures, we can put very nice screws, but you can skip that if you want to go one level below. But I will prefer open because I can get a direct visualized view for my screws and distraction very comfortably here. I will not do decompression in this case, and I will explain them. If need be, then probably we can, but otherwise it's not required.
Right. And one last question to Dr. Srivastav. This patient has asked me, what are the chances that I'll recover? What do you want me to tell her?
I would say that the chances of recovery are good. Yeah, you will improve by 1 grade. So basically, he's Asia C, it seems. So very likely he will be an ambulator over a period of time. And but nothing is set in stone. We can only do so much. But the literature and practice experience shows that incomplete neurology should recover over a period of time. I don't know how much time, but it can take up to 1 year or 2 years also.
I would like to ask Jayswal sir and Dr. Srivastav both, what is the role of steroid for both of you in this particular case?
They're asking from the casualty, should we give steroids? So what should we tell them? Dr. Jayswal?
We in our practice we do give steroids. If in the casualty the patient comes early, then
give steroids.
Give steroids.
Yes, Abhishek.
So it's a very cultural thing. Giving steroids is a cultural thing. I would put it like that, right? Because when I was there in England, the spinal injury unit was dead against giving steroids at the outset. They said that the risks outweigh the benefits of steroid, and there is no conclusive evidence on that. Whereas if you are trained in America, you will definitely give steroids. Whereas also in India, you give in steroids. And also there is a dictum that if you are in doubt, if there is any chance, all the relatives will come to Dr. Nene and tell that, there is this study from Google, I know, why are you not giving steroids? So then I will say, there are risks and benefits, nothing is conclusive, but why not give it? If you feel very strongly about it, we can give it. If it is within 24 hours. If it is out of 24 hours, I would put my foot down and I would say that I'm not going to give steroid and there is no evidence for that.
Perfect. I would like to ask Abhay.
Did this disaster happen because of a steroid in your practice, in so many years of practice?
Sorry?
Dr. Jayswal, have you seen any disaster happening because you gave steroids in your
Not
practice?
really. Not really.
What about Dr. Srivastav?
We had one patient who had bleeding ulcers.
But it was salvageable, right? It was managed conservatively.
It was salvageable.
I would like to ask you,
They
Abhay,
had to-
what is your take, whether you will do intraoperative? Certain surgeons prefer to give intraoperative Solumetrol when they are on that exact job at that level.
Yeah, so I would give pre-op, intra-op, post-op. I would bathe her in steroid because I've really had no problem with steroids, barring a few stress ulcers which can happen because of the trauma also.
Okay.
But my surgery would be different here. It would be open because it's much quicker, 2 surgeons operating at a go. It can be done in an hour, and I would definitely decompress her because if I was a surgeon, I mean, if I was the patient, I don't want my surgeon to go in and not decompress. Whatever the Dixon paper says, if there's a present compression and a partial neurology, I think it's an indication in my head that I want myself decompressed, whether you like it or not. If it was a total neurology, it is still debatable. In a partial neurology, I definitely want decompression. So anyway, we'll convey this to the patient, and Dr. Hadgaonkar, can you take over to the next case?
Yeah. Is the screen there? Yeah.
Yes, we can see your screen. You want to make it a screen show, maybe?
Yeah. Back pain, lower limb weakness, inability to walk. Patient was conscious, oriented but cachexic. Lower limb power was grade 1. And,
Age.
and this is the X-ray.
Shailesh, what was the age of the patient?
He was 57 years.
57 years, okay. Right.
Yes, Abhishek.
So it most likely appears to be a, metastatic or a neoplastic lesion.
Okay.
Based on the MRI. So there is a pathological fracture. There is compression, both from the front as well as the back. The pathology has involved the posterior elements also. So it's like a circumferential kind of lesion. That's what it appears to be. However, because the reflexes are brisk and everything, I would still like to screen the whole spine.
Correct.
So that we don't miss anything on the top, because, there can be multiple skip lesions also.
Yeah.
So these are the things which come to my mind.
Okay. And what all things would you like to do it now on?
So now on, depending on how the neurology has been, if it has been there for some time and it is stable, then I would like to investigate the patient more. And if it is an acute deterioration of neurology, then there is no choice but to go and do something about it. And while we are waiting for all this, I would like to give steroids.
Okay. Any investigations would you like to do now in this?
Well, you have to first of all do an MRI scan, do a whole blood workup, and myeloma screening and things like that, depending on age. And also you have to do, if your center has got PET scan, you can do PET scan. If your center doesn't have a PET scan, you can do a chest, abdomen, pelvis CT contrast. That's the other way of knowing where the primary is. And then you can take a call based on what comes, what is likely to come, and then you have to involve we tend to involve the oncologist very early in the treatment plan, so that we have got an overview of what we are seeing, what life expectancy is gonna be based on what likely pathologies are there, and how can we progress, whether it is worth doing anything in that patient, because the patient is cachexic also. So it has to be a multidisciplinary approach where gradually people have to be involved based on how we progress with the investigations.
Yeah. These patients invariably come with meager resources. So do you choose a biopsy ahead of a PET scan, like if in a typical Indian scenario, Dr. Jayswal?
Well, in the typical Indian scenario, with the present situation where the patient can go for legal advice and other things, also more the reason where a PET scan should be done to look for, as Abhishek said, you're looking at the meds, and then you have to look at the primary. So PET scan is advisable. If not, get a CT scan done of abdomen and other things. So I think there has to be. I mean, it's better to do a thing. And the other advantage of doing a PET scan is if you have a more accessible lesion than this, you can get a biopsy from there. So supposing if it is a lung mets, then you can you can get the tissue from just doing a simple bronchoscopy and get the tissue on. So that's another major advantage. So I would, yes, prefer to get a PET scan done.
Right.
And sir, will you prefer to do a CT, chest, abdo, pelvis, or you, if it is not available in your center, will you advocate to go to other center where it is available? Preferably nowadays, everywhere PET scans are available.
Yeah, PET scans are available, so you can get a PET scan done.
PET scan, you prefer a PET
It's a
scan?
radiological investigation, where a patient does not really have to go into another hospital as such, but a PET scan available in in a big city.
Okay.
But yes, if the PET scan is not available in the city itself, the patient has to go. For example, in Maharashtra, it has to go to Pune or Bombay, 250 and 300 thing. Then there is the
Okay.
advice to do a biopsy and do CT of other places, as Abhishek said.
Okay. 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 Fair enough. So this is the PET scan, and it showed the primary lesion in the lungs, left lower lobe.
Exactly. So here, that is the advantage of a PET scan. You picked it on the chest, and your pulmonologist will be very easily get a bronchial lavage and a bronchial distinct from there and get you the diagnosis. Yeah.
Okay. What next, Abhishek? Now, how will you proceed? Now you have everything in front of you.
What's the primary?
Primary lung.
Rounds.
Okay, so they can take a biopsy, by doing a bronchoscopy
Okay.
and get, what's the type of lesion and what's the life expectancy.
Mm-hmm.
If the life expectancy is, say, more than 6 months, then I would go and do procedure for him.
Okay.
If it is less than 6 months, then, depending on what are the other modalities available, we can go for that.
Okay. Acute deterioration, 4-5 days of sudden worsening of neurology.
Then you have to go and decompress that area, instrument it one above, one below, and take again a biopsy from that area.
Okay.
So that.
Will you consider doing embolization? What is
Well,
your take? You and Jayswal sir.
lung, I would not be very keen on, if it is available freely, then I would not be, very keen on doing a embolization preoperatively. But if it is a kidney, thyroid, something like that, then I would definitely go for an embolization before even I touch that tumor.
Yes, Jayswal sir.
Even any meds, even in a pulmonary meds, I would do an embolization. Yeah.
You will do embolization. Okay.
Readily available, we'll do an embolization.
It makes life very easy.
Life easier, yeah.
So I just had one question. Abhishek, will you not want to do scorings and all? Supposing the oncologist says that he's got a mere 3 months on their on their score to live, but he has suffered this major neurological deterioration. How would you put yourself in this whole scheme of things?
I would be very, open with the family. I would say there are 2 scenarios for him. One is that I operate on him. He stays in hospital. He comes in and out. The chances of recovery, if the neurology has been long-standing, the neurological recovery is very low. And he has got 3 months. So there are 2 options. As a humanitarian doctor, I would say that, you take him home. Let him be in the care of the, family members. Get a nurse who can take care of him. And at least he will pass, his last days with his family, with everyone around, rather than being with people who he doesn't know. There are lots of lines which are painful, and he's undergoing through a lot of procedures. So that is my personal take on it, because that is what I have seen in England. A lot of patients who were at the end of the care, they would have been automatically put on what is called as Liverpool care pathway, LCP, where they will be taken care more of as a palliative case, rather than being push them towards surgery and then going in and out of hospital, then being from hospital to a nursing home, lower care facility where they are away from the family. But if the
push this-
patient says,
yeah.
I want to try and I want this to be done, then I am happy to offer a procedure.
Yeah, so I'm going to push you in a slight corner and say that instead of 3 months, the oncologist says he's got 6 months to live. Do you have some kind of a line in your head that you say?
Yes, for me it's less than 3 months. But if the family and everyone is understandable, then I can go up to 6 months also. Well, 6 months I will do something for the patient.
Right, Dr. Jayswal, do you have any such?
No, any surgery that you do is a palliative, right? To sort of even if you have 3 months or 6 months time, make him comfortable. So one if there's a severe neurological deficit, especially if there's a cardiac equina, there's a bowel blood involvement, then even with a 3 or 6 months fracture, I would quickly go in and do a local decompression, stabilize 1 or 2 above, 2 below, even percutaneous, and give him a chance to have even if it is a wheelchair life, at least he'll be able to be slightly more independent. And there is so palliative surgery, even with the low scorings in other systems also, that allows you a leverage to go and do a palliative surgery. So decompression, if the neurology, depending on what severe neurology it is, and then there is rationale to give him surgery. But again, quick short surgery, not a big reconstructive surgery.
Yeah.
And
any of you folks, any interest or any experience with SBRT, like cyberknife surgery for these end of life or even very, very elderly metastases with urology?
No.
Yeah, Dr. Hadgaonkar, what was your take and how did you?
No, I think the movie Anant, lymphosarcoma of intestine. I think the days are different now. We have better answer with the oncologist and.
Shailesh is a very filmy guy, yeah. I must warn you.
No, that 3 months ka life bacha hai, aisa nahi hai, because now most of we really have very good oncology treatment, and I think we have to be rational to understand Tomita, Tokuhashi, Boriani, sin scoring. Once we know that prognostication is better 6 months or plus 1-2 years, I think whatever we should try to give the best possible life. That's what I feel. And we should not just let go because we are seeing patients with adeno-CA 2 to 3 years, they are coming back to us. They are doing fine, and we should try to give the best possible answer. That's what I feel. What we did was we did the embolization, as Jayswal sir said. We believe in embolization, and pre-operatively, if you see, and post-embolization, we had a very good 95% blockage of the vascularity.
Fairly vascular tumor. There was a big blush.
Absolutely.
On the left side, a big blush there, yeah.
Absolutely. I believe in what you said, sir. Most of the cases, I prefer to do that. And we did a complete decompression. We did a vertebral column resection and fixation. And he had a fairly good life, I would say. Any quick comments?
Would you have done this, Dr. Jayswal?
I would have just done if this was adenocarcinoma and the life expectancy was not too much, then I would not have sort of had such a long procedure and so much of blood transfusion. I would have just done a local decompression and stabilization above and below with percutaneously. Yeah.
So luckily there, because of the invasion, there was not much of bleeding.
And if required, if I found that if the CT shows the big anterior column defect, this was one condition when I would then stabilize the anterior column slightly and quickly with Abhay's cement.
Yes,
Dr. Srivastav, would you agree with this procedure?
So, I would like to ask Shailesh, what was the life expectancy given by the oncologist?
More than 1 year.
More than 1 year. Okay. So then I would not have put a cage, as you know. And is there any plan for chemotherapy for this patient?
Yeah, he was immediately transferred to the chemo unit.
And any radiotherapy?
Yeah, chemo plus radio.
So when you are planning radiotherapy, I would be very reluctant to put something anteriorly, in like the form of cage or something. Because anyway, the graft will melt away. There will be a lot of scatter because of that. So then I think cement is a better option, what I feel. And I would not have gone so long. I would have done a short fusion to preserve time and, everything. But definitely, as I told you, embolization,
This was L2, no? Therefore, it is better to, that's the only reason we went one level above. Otherwise, Otherwise, short can be also.
No, you have done a very nice job. I'm not saying that, but it's just that I would have tried to stay short in this.
Okay.
The other thing is, Shailesh, my objection is that you
Yes, sir.
stopped at, the other thing is you stopped at T12, right?
Yes, sir.
So that is another sugar.
D11, sir. D11.
That's 11? Okay.
Yeah.
Okay. Then that's okay. If you cross the thoracic lumbar junction.
Yeah, and this is what Abhishek said is right. This is a little older case, but I agree with you for the cement plus cage. That's the right thing, I think. Recently, we were seeing these cases from the Shanghai hospital, the tumor hospitals, and they are doing absolutely bone cementing where they are showing very good outcomes. Yes, Abhay, quick remarks and we go to the next.
No, all good. No remarks. It's a good learning, and I think we are getting more and more aggressive on our spinal tumors. So the next lady has been waiting very eagerly for a long time because she's the one who makes all of us bakras. And I have told her that we'll be happy to transfer her to Primus Hospital in Delhi as soon as our experts give their plan. So she's eagerly waiting for the two of you all to take over. But before that, I need to present the situation to her. She's this deformed elderly lady, very frail, had a significant weight loss, sarcopenia in the last couple of years. And she's very, very disabled. This is what her X-ray looks like. She's claudicating. She has back pain. She's got difficulty in just maintaining her posture. This is how she looks from the side. And there's a compensation, as you can see, in the hips and the knees. She's kyphosing you can see the lateral X-ray. She's scoliosing, and she's grossly osteoporotic. She's in the -4, -5 kind of range. But otherwise, her engine is running well. She's like heart and lungs are all fine. So she's saying, "Hamara tin work karke do, gaadi chalana hai." So the experts, Dr. Jayswal, what's your immediate take on this lady?
You'll have to sort of talk to the patient, the relatives, anesthesia, multidisciplinary approach to look at mobility evaluation and her risk and things like that. Because look, basically she has, her most disabling thing perhaps is the claudication and leg pain, right? And predominantly L3, 4, 4, 5, really. So we're looking at two scenarios: either do a quick local decompression and local stabilization, or go all the way up and address the scoli. And
so just to show you the actions, the compression is really not that significant. The compression on the lying down MRI, if you notice, is
but then the foramina are really, really tight out there.
Right. I just wanted to bring that to your notice because we all felt it was more dynamic rather than.
Yeah. So centrally, she has like pain. She must be having like claudication because of the lateral foramina are very, very tight. So she has stenotic element also, and plus the back pain element. And then if you see the CT or the MRI coronal cut, there's a definite lateral subluxation. So if the patient is willing, and if you are there in the coronal plane, there's a big lateral subluxation also.
Absolutely.
Very, very unstable. So it is a problem there. So if your patient is agreeable, if the anesthetist is agreeable, ideally you would like to go up to T10 and go into the sacrum and do the decompression restrict to 2 levels or 3 levels and correct her SAG profile as the lateral and profile. There are a long workup. But of course, it's very, very important that you have to look at her osteoporotic index and also treat her with a teriparatide 40 to start with, and then go ahead and do it. So the option, you have to weigh the option: local 2-level decompression, local stabilization versus a long construct, and that you got to talk to the patient's relatives, look at the morbid factors, and multidisciplinary approach to that.
So, Dr. Hadgaonkar, what would you actually talk to the patient about? Like because she's clueless. She's going to say, okay, give me a small option and a big option. And any day, if a small option works for me, I want that. So how would you counsel her on the
I think at 77 and back pain, leg pain, claudication, all these things. It is most important to understand the psychology, the background of the patient, the demands of the patient, and the family understanding. Something like degenerative auto-stabilization is a concept which we have started believing now, but we in the past we have done a lot of deformity correction for degenerative scoliosis, but now we are realizing that there is a good answer for short segment decompression also, because most of the time this spine, though it looks crooked, but it is reasonably stable. And if you get the leg pain off, probably they do very well. And if she's asking for only leg pain, and if she understands well, probably I will do only decompression for these 2-3 levels, and continue her with some kind of bracing and activities.
Right. So, Dr. Jayswal, are we here going against this whole new subject in spine surgery that has been developed in the West, saying that if you decompress such individuals, I mean, their main problem is their balance, and their sagittal balance is bad, and the nerve compression not an issue. It's really how their hamstrings and their glutea are firing away just to keep them upright. And you're doing disservice by doing decompression unless you give them a good sagittal balance. You're creating a monster. Are we really going against that based on our experience? What do you think?
Even in the West, people are now going a little more conservative, and short segment fixation and decompression is coming back, because there are a lot of problems really on long fixations, and correcting the PI minus LL to that great extent, and going and doing aligning the sagittal balance, and there are a lot of problems also which add on and going to the pelvis. Does get an out. Yes, the advantage initially is that the patient's overall improves, but patients do land up with a lot of complications, and even peroperative and postoperative management. So as Shailesh also said, that there are massive benefits of local decompression and fixation, but there are definitely benefits of large fixation as such.
So where I'm coming from
talk to the patient. The other major advantage that we have in our country, we have people to take care of these people. You talk to them and they say, okay, if you can just allow me to go to the toilet independently, or go to my for my prayers, I mean, I'm okay with that. And the patient's attendant also would say that's okay there. So the question then occurs that are we really justified in giving them so much of mobility and mortality as such. So there, it can work either way. It depends on how you want to take it. And again, as Abhishek had said earlier, it's the cultural problem, and culturally factors have to be tailored into it in your decision making.
So I just want to come in here again and throw in another spanner in your works. That if this patient went to Amit Jhala or to Dhruvin Patel, they would offer her a multi-segment olive, and follow that up by a quick percutaneous long segment correction, and that will give her a much better radiological outcome at the end. Are you happy to proceed on those lines vis-a-vis your approach of a quick in, quick out shot?
Even if you're doing 3 levels of olive and then flipping her over and doing percutaneous fixation above and below, even there you're giving lot of exposure to the patient and a long surgery to the patient. If you're doing it, you would still do a local decompression, do it all posteriorly also. That's not a big issue there. The question is the long surgery versus short surgery. That's basically the issue.
Very interesting you say this. I just want to ask you on the behalf of the entire audience that's listening, because these are very, very important things that you're telling us. Have you been there and come back? Are you generally cynical, or this has worked for you, so you just want to stick with it, and why change something that's working?
No, like we have patients who are now going in for the long surgeries, and we started with the local decompression short fusions to start with, and then when we we do as deformity surgeons, we also looked at and doing surgeries from top to bottom. We did do that, and some patients have done well, especially the younger elderlies. If you're looking at a 65-year-old lady or a 70-year-old lady who's very well maintained and things like that, they would generally do well, and they have a span of 25, 30 years. And now that you have you're geared to do all this and you're more experienced, it is worthwhile giving it. But a 78 years, 79, 80-year-old lady, she would want to sort of move around in the house and be more comfortable. Then why give her all the morbidity and mortality? So that's again the cultural differences come in. And that's how we address these patients. That's how we look at them. Yes, there are patients who have very, very disabled. We do give them, but it's not that 78 and 80-year-old lady, or we see a lateral subluxation will go above and to TTN to pelvis. It's not really.
Very important. So I'm going to ask the young gun. There's a young gun here who's very aggressive. He's called Shah Rukh Khan of spine surgery. That the guy on your right, Dr. Hadgaonkar. Would you buy this chota mota option, or you want to go and show your prowess and rest the initiative and correct everything? You're muted, sir.
I think it's demand versus supply. The demand of the family, demand of the patient, how significant is back pain, how much.
But you can see her demands are very high. She's active, her engine is running well, and she's come here because she's not able to stand.
Yeah, if this is the scenario, I'll definitely go for multi-level correction and decompression.
Like the whole hog,
Yes.
the American operation.
Yes.
And have you burnt your fingers doing these operations in the past?
Yeah, means we have done quite a lot of this, and a couple of them had some issues, adjacent segment or implant problems because of osteoporosis, but we have to accept it because it's a dialogue and a discussion with the patient and family is very, very important. All these things can happen, but there are very good outcomes also at the same time, who are doing really very good for even a couple of years now.
Right. And quickly, have you had bad results with Dr. Jayswal's options?
Probably no.
So you're just better is the enemy of good. Like something's good, but this is better, so I want to do it.
Yeah.
Okay, Dr. Jayswal, one last question. You see the top picture on the top right. She was all set for operation, and the previous night during shaving, we noticed the skin looks like this. This must have happened in your practice also quite often. What would you do? Would you just go ahead with the surgery, or would you postpone the operation?
No, what exactly is it?
He's a bit itchy on the skin.
Dermatitis sort of a thing?
Yeah, we don't know the diagnosis. She said, I feel itchy, but this is what it looks.
No, I'm definitely not going at all. At this elderly age group, we'll have to have a look at that dermatologist, even at the risk of cancelling the case. I would just go.
Right.
Get this care, because once the infection goes up with low immunity, you've had it. So would not.
Okay.
So excellent discussion, and this is exactly what we wanted from the Tiger of Delhi, and he's given what we wanted. So thank you, sir, for this. Dr. Hadgaonkar, your case?
Yeah. I'm just. Yeah, we are in the lumbar ward, and we'll continue with the low back. And this is again a 73-year-old lady with back pain, significant claudication, lower limb radiation, claudication less than 50 meters. And this is the X-ray and MRI. This is the X-ray and this is the MR. How will you approach, sir, now?
Well, again, a similar sort of a situation here, 73-year-old lady, but her predominant symptoms are claudication and leg pain, right?
Yes, back pain as well as leg pain. Significant back pain, sitting pain, and leg pain.
So either which way, again, 3-level stenosis is a problem, and of course there is a thoracolumbar kyphosis there. Sagittal balance is also a problem there. So again, same principles apply here. And if you can get away with a local decompression and talk to the patient 3-level, and patient does all right, and you can offer that as compared to going up, because she doesn't have a coronal imbalance, but definitely sagittal. If you look at the parameters there, there is the local kyphosis here. But
Yeah.
I would in this particular patient would probably get away with 2-3 level decompression.
There's a vacuum sign at multi-level. This 2, 3,
Yeah,
3,
but not
4.
higher up, at 4-5 basically, and 2-3.
Yeah.
So you can get away. There's a kyphosis at the thoracolumbar junction.
Okay.
So you go
Okay.
up
We can get away.
and align a sagittal balance. Again, the question is how much disabled she is and how
Almost 3 years she's suffering. Been to many doctors, many treatments, all the pathies she's tried,
Yeah.
including
So-
naturopathy for back pain.
two level injections here at transfer foraminal injections are there, and let us see that is basically showing how much benefit she's getting in this by injection, and that will also give you some help towards whether you need to do and fuse long or just get at the local decompression and get away with that. That also at times helps and helps the patient also.
This is a very high demanding Mumbai lady, South Mumbai lady who comes to you, Abhay. And how will you manage now? She wants to get better, enough of medications. Back pain is significant, sitting pain, can't walk much, leg pain.
So I'm very sure that this is a simple lumbar stenosis. This is not a complex lumbar stenosis. The kyphosis is developmental. If you see the shape of the bones, it's not wedging of osteoporotic bones. It's how the bone is formed. It's like an old Schurman's, or if you see the bones are, puckered, and that's how, she's probably lived with this thoracolumbar kyphosis forever. It's a balanced spine. It's not an imbalanced spine. If you drop the plumb line, you're not going off too much. There is severe compression. The compression, unlike the last case, which was iffy, here the compression is like on the face. So I'm very sure that I'm going to offer her an L2-3, L3-4, and L4-5 laminectomy and decompression, and that's that. Even if she begs for a fusion, I'm not going to offer a fusion. I have no worries about the vacuum signs because that only suggests axial instability, which I'm sure a 73-year-old, even a high demand lady, is going to be able to live with. If I start fusing her, I'll have to go to the mid-thoracic spine because I'm not going to be able to stop at a thoracolumbar junction. It's kyphosing and it's going to, throw the biomechanics of compensation away. So I think there is no option asides of decompression alone.
And
you can stop you can stop at 2 and get away with it if you want. You can stop at 2 and get.
But so I feel the compensation which the lumbar mobility offers is going to go away the minute I fuse.
And the Americans would again argue that if you look at the pelvic parameters, there's the definite sagittal imbalance. The patient test, if you look at the CVA also.
Can you show the X-ray, Dr. Hadgaonkar?
Yeah.
Because I feel the sacrum is nicely sloping well. The angle also looks big. The angle of containment looks big. So, the hip is quite anterior. So
Dr. Nene, nowadays they say if you instrument, there is a better chance of a wide decompression. What's your take on it?
No, this is almost an auto-stable spine, but I'm just putting another, idea that if someone, insists that I would do a soft stabilization, I would do a Dinesis kind of a stabilization here, a pedicle screw-based soft stabilization. If someone insists, but I'm sure I'll be able to do a good wide because she's got central hard discs.
Jayswal sir, what you will do in Delhi? A very high demanding patient comes to you and she's demanding this back and leg pain both. What your best?
Then again, I would talk to her, and like I said, I would give injection and let her walk for some time and see if we can just get away with the decompressions alone and by injections. But if I'm doing a decompression and if it is a 3 level decompression, I would stabilize her. I would not just without stabilization as compared to what Abhay said, just pure decompression. I would not. But I may not. If the patient is okay with that, I don't have to go up and do a T10 to S1 or iliac fusion. I would not.
We'll go a short L2 to L5. Okay. We did the same, and patient's pain was better on day 1, and next day she complained of leg pain again. How will you assess this situation, sir?
Depending on what your leg pain is, what is your leg pain? 2 days later, if she has it, then there are certain things which you'll have to keep in mind, that like if it is a root pain or is it a complete leg pain. You have to examine
Calf pain.
Calf pain. If there's a calf pain, then Then you also have to rule out, elderly lady, a DVT, you have to rule out, right? And you also have to rule out things like, if post-operatively there's a hematoma and things like that. Before you straight away jump into getting an MRI done to look at if there's a compression there which is left behind and things like that. You have to do all these things, and of course, you have to do your evaluation for DVT and also look for anything. Give her some painkiller and see what it is like. You see, it's the right side. Right
Yeah,
side
the
is
right side. Spot on, sir. Means absolutely what you said is absolutely right.
swollen. If you look at it from that front view, the right side looks swollen. So
Yeah.
you need to do a evaluation, ultrasound and things like that to look at that.
Yes, sir. Yes, sir.
And
Yes,
and
Abhay,
a patient has pain, like pain post-operatively, and you always think, what have I done? And you like you worsen it, or look at thing, and you straight away send the patient to MRI. I think you should always wait and do a good examination before you really jump into even getting an MRI done.
yes, sir. Abhay, any quick comments?
No, I think there's an algorithm that every unit should follow for post-op leg pain. And the first line of the algorithm is senior evaluation. Your registrar can no longer round and report. You have to go and check the patient, evaluate the patient, because everyone else is going to miss this DVT. The other is documentation. And the third important thing is counseling. You've got to tell the patient that it's unusual to get leg pain post-op. So I'm not overtly worried, but I want to keep a watch on this and talk to the patient transparently, the possible causes in your head, what you're thinking through, and the possible outcomes of that, and so the patient understands that she's not being taken lightly, and then she's willing to accept even the DVT or even a medialized screw for that matter.
Yeah. Well said. Perfect. Jayswal sir and Abhay. Should we go to the next case quickly?
Yes.
This is a 65-year-old obese lady. She had a slip in bathroom and persistent pain, increasing pain, and worsening pain. And last 8 to 10 days, difficulty to get up, stand, and turn around. The X-ray reveals there is a fracture above. T-score was -3. Yes, sir. Jayswal, sir.
Okay, so basically now she has back pain, right? And this is after a slip. So
yeah, porosis and back pain.
So you see osteoporosis, you have to look at the medical management, give her a support, and see how she behaves, right? And there's no need straight away to go in and jump in and do surgery. Treat her, conserve her, and see how she progresses. And you have to observe the osteoporotic area there. Also, and particularly if there's no leg pain, then you don't even really need to have an MRI done or to look at things like adjacent segment and things like that. If there's a back pain there, take it as an osteoporotic fracture there. Look at her and treat her osteoporosis and give her some support and let her move around and then observe her.
So it was done, and at 3 months the pain was persistent and it was worsening.
Okay.
Not better.
Mm-hmm. And what does the X-ray show?
X-ray showed some collapse. Right now I'm not having that X-ray, but there was some collapse. Yeah. We have the MR.
So get an MRI done. Okay. If she's persisting and things like that, then get an MRI done. Okay. So there is a collapse there. There is a vertebral collapse there, and that is osteoporotic. And in fact, the vertebra below that also they had an old collapse.
Yeah, inferior end plate collapse. Yeah.
So that was there. So this is most likely to be an osteoporotic collapse, and I would still not like to extend the construct higher up.
Would you consider vertebroplasty or something in view of her pain, back pain mainly, sitting pain?
I mean, like I said earlier, I'm not too big a fan of vertebroplasty now. They used to do a lot of that. Given up, if at all, if it is worsening, if you say it is sort of incapacitating the pain, then I would go up and stabilize her rather than percutaneously stabilize her.
Yeah, she was a quite obese lady, and if you look at her, she was quite obese, sitting pain and suffering a lot.
Like I burned my boards, burned my hands with vertebroplasty, and especially on the top of a construct, it will keep going up and up under. But I would, if I have to intervene, if I'm really convinced that a pain is not improving,
Yeah.
I would do percutaneous fixation and hook on the top, and add on to the lateral
Okay.
connected, then lateral connected, add on to the implant. Rather than do a vertebroplasty. I used to do a lot of those. I'm not doing them anymore.
Okay.
Yeah, I would do something like that. Yeah. The only difference is I'll put a hook on top, and that has been my routine practice now. On top, I do a soft lying with hooks.
Okay. Okay. Yes, Abhay.
So I am not in agreement with what was done because I mean the cause of the pain is an intraosseous instability, if at all. First, I need to prove it. The MRI doesn't tell me what's the cause of the pain. I would have done a sitting lying down X-ray to really know if there's a non-union, because the MRI doesn't suggest any Kumels or anything. If I could spot a non-union, I would pack it with cement, but with the same fear as Dr. Jayswal, I would do cementing at many levels, like a preemptive cement at multiple levels, and that seems to take away the possibility of an adjacent. Remember, there's always an adjacent segment next to an adjacent segment. So you
Yeah.
may have won the battle,
Yeah.
but you might still be losing the war by extending the fixation.
And now you start teriparatide and things like that.
Yeah, so that's the final nail in the coffin of this surgery. That teriparatide is available to you. Why do you want to put in screws above? So when teriparatide can save the day, especially when
So
there's no
started
urology.
at 1 month by
Because screw versus cement. Cement. They really, cement does not amalgamate with the bone. It just comes out. Or it does not sort of get absorbed in the bone. So there's always
I
a
am also not a fan of it, sir.
It
Yeah, I
also
think none of us are. But
it
in the
also
time of
stiffens.
teriparatide, vertebroplasty is almost given up. But then teriparatide is medical vertebroplasty. So that is.
Yeah, but at times teriparatide alone will not. Anyway, so that's okay, right? Yeah.
Yeah, so we've got three different opinions on the same case, which adds to the flavor of the Saturday or
Thank
Friday.
you, sir. Thank you very much.
Yeah.
And
Now, before you get this case on, I had to say this line. I've been preparing this line. You can't get MS Dhoni on show and not play the helicopter shot, right? So you can't have Arvind Jayswal on the show and not have an early onset scoliosis case. So, Shailu, I'm hoping you're
yeah. No, I just would like to talk about this. And this patient is in Pune, and we are following up this patient, which was treated exclusively by Jayswal sir for almost 7 to 8 years, and we were lucky to have this case with us. And I would like to enlighten the early onset scoliosis, what sir is known for worldwide. And luckily, this is the case which is with us now, and we are following up. This is a 9-year-old syndromic scoliosis, right thoracic, left lumbar were structural curves, coronal imbalance, right shoulder was higher, tethered cord.
So
Shailesh,
there
let's
is a
go back.
generation in this
She
crowd
also
that has totally missed out on how you were when you were young, and that's why it's up to us who are the mid levelers to say that you were really the guy who started doing early onset scoliosis in the country, and
Yeah.
you have the largest experience by far, and you are the one who holds the torch of the Indian EOS group.
I'll cut you short away. Let's go back to the case. Okay. Can you take this here? Also to notice, if you can point with your pointer, Shailesh, look at the knee of the girl. So she had a lot of other deformities if you such, So she had that. Can you go on to the X-rays now?
So we would like you to give a running commentary, and we would like to listen to what I will scroll through the.
So if I may, sir, there is no limb length discrepancy. There is already a intraneural surgery done. It's a double major curve of a significant denomination in a walking child. So it's a unique problem in terms of even an EOS. So how do you look at this in that light, sir?
Yeah, and actually, if I remember correctly, that she had, you need to get a CT done, the MRI done, because she also had a.
We luckily got everything.
God, so.
So why CT, sir? Dr. Jayswal, why CT?
She had kept everything with her.
I normally it's a complete routine workup done, and I will get a CT done, because in X-ray times you cannot make out if there's the vertebral defects as such. So CT gives you an idea of what the entire vertebrae looks like. Also routine CT when we do, our radiologist gives us the pedicular cuts at the different levels. So we know the status of the pedicles also when in small kids, when you're putting in your screws or things like that, you have to do that. So basically to delineate your deformity nicely, you get a CT done. It's a routine with us. So Abhay, take it up from there. What would you sort of do? Yeah, this patient, can you have the next?
I think this idea of CT is great because I have suffered at least more than once by not doing a CT and missing out on a potential hemivertebra.
Yeah.
And this hemivertebra in a particular case was posterior, and I kept treating him as a scoliosis, and in the end he started kyphosing when the growth spurt happened. So I think that's an important take-home message.
Absolutely.
When in doubt, just do a CT and clarify how things look on the outside. So the question here is going to be external versus internal splintage. So any algorithm for that, Dr. Jayswal? She's quite an older child. She's 9 years old.
9 years, yeah.
So what makes you want to do an external splintage rather than internal splintage here?
I don't know. Shailesh will be able to tell me the exact history. I think she came earlier, and this is the time when she presented 9 years old. Earlier, she was treated by a brace. So in very small kids, you tend to use a brace somehow. And then if the curves are progressing, or the other problems are there, and then you think of it to do an internal.
Sir, if I may, is there an age or weight cutoff for brace versus growth rod in your head?
Yeah, actually, over our experience wise also, and what literature says earlier the when you saw a patient, EOAS, you would straight away go in for a growth rod, and even a 4-year-old kid and a 3-year-old kid, you've done it, I've done it, and then we've seen the problems and complications are much more. So with a growth rod, ideal age is now is around 6 to 8 years, so that you can carry your growth rod for another two years or max 3 years, get them on to 10 years plus, and then go and do a definitive fusion. So that's the idea. So try to use casts are coming back again. The cast, the very small kid use cast or brace to buy some time.
So that is the other follow-up question. Is there a good age for cast versus brace? How do you throw that in your head?
What I do with the small kid, say a 4-year-old kid comes to us. What we do, I mean, cast is able to sort of hold your curve in a better way than the brace. That there's no question on that. Number two, you can give them a GA and then get more correction out of the cast, but you'll have to repeat it. But the flip side also is that's not very comfortable, especially in our condition. So what I've started doing in very small kids, I start them on the casting, especially if the deformity is more than 40 years old, 40 degrees in a small child. Put them in a cast. First cast would be under GA, and then the second cast without GA, patient knows what's being done, and then during summers I'll put them on a brace, tight fitting brace. So get them over for 3-4 months in a brace, and then get them back during winters. In Delhi, for example, we get winters, and so then put them back in a cast, and only if they become rigid then you do. So first brace first casting is now under GA. The rest are all under sedation and by just talking them over and alternate with the brace.
And finally, sir, why did we choose a brace that went up to the mandible here rather than an underarm brace?
Yeah, this was because this was the old Milwaukee brace, and it's like a traction. It keeps the upper thoracic also very well sort of under control. But the only thing is the compliance of the brace is a problem. But of all the brace, even today, this gives a very good sort of support to the spine, especially to a growing spine. If the curve is proximal to T4 or so like that.
Right.
Okay. Luckily, and the patient's complete family is following up with us now nearly 1 year, sir. You operated her 8 years back and then you continued. Then, yeah.
So,
And
so
this is the immediate post-op. Yes, Abhay.
I mean, can you go to the post-op image?
Yeah,
Because
I'll go to
I'd
the
like to
post-op.
ask again a few questions on behalf of all of us. That magic rod is a great sensational new thing, and there's no doubt that it's a great new thing. But as a devil's advocate, it does not go away from the original problems of growth rod, which is a 2-point distraction. And this is just merely achieving a 2-point distraction in a more slick manner.
Yes.
What are your comments on that vis-a-vis an apical holding system like a Sheila, where you have screws at the apex and you try to get some correction and get a 3D correction rather than just a 2-point stretch, sir?
You see, the principle is same for both the conventional as well as magnetic growing rod. Like you rightly said, you have ankles at the top and ankles at the bottom. The major advantage of a magnetic growing rod is of course that you don't have to call the patient for GA, number one, and for distraction you don't have to give a GA for every call them every 6 months. That's a big advantage. The other advantage in magnetic rod is you do distraction more frequently. That means every 6 weeks, 8 weeks, you call them and do distraction as an outpatient. And then when you're distracting, you can sort of know what the patient is getting, any leg pain and things like that. So there are definite major advantages, but the cost is very, very prohibitive, right? So between growing rod and magnetic rod, the magnetic rods are better. But again, over a period of time, we've done a lot of conventional growing rod also. The advantage of a conventional growing rod is, if you look at the sagittal profile here up, you see it's absolutely straight there. But if you had a conventional growing rod, by putting your dominoes in a very judicious manner, and you're distracting only the thoracic spine, if you distract the thoracic spine from top and bottom, you would get some amount of normal sagittal balance. Whereas magnetic rod, there's hardly any space between the main construct, the body, and the top. So you can't bend in your kyphosis and your sagittal curves into it. So that is there. Now coming to your Sheila versus magnetic rod, Sheila has got their own. Number one, this curve is not amenable to Sheila because it's a double curve, right? So you need to have distract on top and bottom to really get that. Sheila, where would you put your fusion there? In the cervical spine, in the thoracic spine? Then what about the lumbar spine? So Sheila is not a good procedure here. And between growing rod and Sheila, we've done some Sheila, but growing rods are better to control your curve than Sheila itself.
Fantastic. So that covers everything that we were asking.
Yeah. So this is at the age of 9, and we'll have to go up to the age of 16. Where we have all the follow-up and luckily all the imaging here.
This is, I think, an epic case. Can you go ahead, Shailesh? The sequence of events.
So you can see this was the 87-80 degree curve, and just by at the first go itself, when you put in the rod, you get a very good correction, 50-60% correction. And that's how she looked.
Yeah, can you see that, Abhay? Yeah. And now the distraction starts.
So what about the other problems of anchor backouts, etc.? Did you face any during this long, this long story with this girl?
Not really. It did slightly back out. If you see the lower, you use your cursor. I can't use my cursor.
Yeah, the bottom right image.
Yeah, these screws started pulling out. But the maintenance of balance, number one, and the curve sort of cobs is maintained even if they started pulling out at the back. Can you go down? Can you go to the next?
So you didn't really have to go in again. This kind of pulled on.
Yeah. So like you'd already carried her for a year, so she would be now about 9. Can you go back in just one moment?
Yes, sir.
What I want to show you guys is this. In magnetic rod, you can see like if you start, Shailesh, you'll have to use your cursor at the You see that's the first distraction 1D. Yeah. If you see the red arrow, where you can see the notches there and see the distance of distraction. Now you come to the 6D picture right on the right,
Yeah.
and you see these notches have gone. So that shows that the the rod has distracted, and you've got length there, right? So that is another thing which I wanted to show.
Yeah. We go to the next.
That's when we started thinking of, look, she needs to have a surgery done. The lower screws are backing out, and she'd already by this time had achieved an age of, I think it was 10 years or so.
Yeah,
So
11 years. Now she was 11 and a half. Yeah.
Yeah, that time we spoke to her and he said, hey, look, the parents were very educated and, that sort of a thing. Let's wait for some time, but at some stage, because their lower ankles are pulling out, then, we'll have to go in.
Yes.
But any case, we went in and did a final fusion.
Yeah. Excellent. We have these excellent images of this girl.
And if you can see the height of the child is really, she's not taller than her mother.
Yeah. Now this is 16 years.
It's almost unheard of for growth rod, early onset kids who present so early to grow so well. And
look at how she was before, Abhay.
I mean, she was out of a Star Wars movie, and now she's like a regular.
No, it is not always hunky-dory, like as we all know.
Yeah.
So,
and they're really grateful to you whenever they come to me, because their family is coming to me for showing some back and neck pains, and they're extremely, they keep talking about Dr. Jayswal only. So
okay, let's move on. Come on.
Kudos to that. We are at 8:15, Shailesh. I think we've
cracked.
Yeah.
Hey, thanks, guys.
Out of his comfort zone for a long time. Though this is his comfort zone, I think.
Thank you, Jayswal sir, for giving your extremely great time for all of us. And this was something a very different learning for myself for sure, and Abhay for sure, and most of us to learn from such a stalwart. Also, I would like to express my gratitude and thanks to Dr. Abhishek Srivastav, who gave excellent time for us and his expertise for this grand rounds, which was premiered worldwide. And I would like to thank Dr. Ashok Sham, Dr. Neeraj Bijlani from OrthoTV, the Indian Orthopaedic Research Group, and their alliance at many countries who are watching this live, for giving us a great support. At the same time, I would like to thank Dr. Ajit Shinde from Maharashtra Orthopaedic Association, who is the president, and Dr. Narayan Karne sir, who is the president of Pune Orthopaedic Society, Dr. Parag Sanjeti, who is the chairman and director of Sanjeti Hospital, Pune, for giving us this wonderful platform for meeting with these legends from India and all across the globe. We really miss Dr. Anant Tambe, who was unfortunately stuck in an emergency situation today, but we'll definitely catch him soon. And I would like to say thank you, Dr. Jayswal, once again for this wonderful grand rounds.
Thank you, guys. Thanks, Shailesh. Thanks, Abhay. It was a great learning experience for me, and thanks everybody for organizing this. And everybody stay safe and happy.
Thank you so much. Have a lovely weekend, sir. Thank you.
You too. Great.
Thank you very much. Thank you all.
Go back to your music, Abhay.
Yeah, Dr. Sham.
Yes.
We had just completed the rounds.
Okay, so I'll be disconnecting the stream.
Yes.